So we'll be discussing about advances in the endoscopic management of pancreaticobiliary diseases, case-based approach. So for this, we have one tool with us, which is endoscopic ultrasound. It's primarily a endoscope on the tip of which ultrasound probe is attached. It was primarily meant for imaging of the pancreas in 1980, and then it was used for multiple purposes. So what we use for intervention is primarily a linear endoscopic ultrasound, which produces image at right angles to the axis of the scope. Radial is predominantly used for diagnostic purposes. It produces image parallel right angle to the axis of the scope, and images are similar to that of a CT scan, and hence it is easy to interpret. So this is the typical wall layers that you see on endoscopic ultrasound, and this resolution cannot be achieved with any other imaging modality. Primarily on EUS, you get 5 layers in GI tract. These are 2 hypo and 3 hyperechoic layers. Hypo means black layers. These are primarily muscularis mucosa and muscularis propria. So we will be discussing about benign and malignant pancreaticobiliary diseases. In malignant diseases, the focus will be on pancreatic cancer, gallbladder cancer, and the bile duct cancer, and symptoms related to this, which are predominantly biliary obstruction, outlet obstruction, and pain. In benign, we will be discussing about pseudoaneurysm, which is related to acute or chronic pancreatitis. So we begin with the case. A 75 male retired police officer, diabetic, presented with progressive jaundice, pruritus, and anorexia for 6 weeks. There was a weight loss of 10 kg, social alcoholic and past smoker. Examination revealed deep jaundice, mild pedal edema, and pallor. Liver was 18 centimeters large and gallbladder was palpable. Investigation revealed a total leukocyte count of 15,000. Bilirubin of 19.5, direct of 13, raised transaminases, and alkaline phosphatase to the tune of around 500. A CT scan was done which showed enlarged liver. Intrahepatic biliary radicals were dilated. The bile duct was dilated till lower end. It was around 31 millimeter in size. GB was distended with stones. There was a mass in the ampullary region and presence of retroperitoneal lymph node. Side wing endoscopy was done, which revealed an ampullary mass. Biopsy was convincing of adenocarcinoma. So what we have in this case till now is a malignant extrahepatic biliary obstruction caused periampullary cancer with retroperitoneal lymphadenopathy. Now the intention was to stage this, for which 2 modalities are commonly used. This is ultrasound or a CT guided FNA, and endoscopic ultrasound with or without FNA. So which to choose among these remains an issue. So CT guided biopsy of a retroperitoneal lymph node has got a high sensitivity and specificity of 100%, accuracy to the tune of 93%. EUS guided FNA is minimally invasive, safe, can be done for small lesions with high sensitivity and specificity. The major difference here is the EUS guided FNA, as has been shown in studies, the needle tract seeding for CA pancreas is to the tune of 2.2% compared to a CT guided FNA, which is to the tune of 16.3%. So what has been recommended is EUS FNA is a primary diagnostic technique for tissue diagnosis of mediastinal or abdominal lymphadenopathy of unknown etiology, for which there was a strong consensus. So in this particular case, what we did is, you can see scope is positioned in the second portion of the duodenum. This small lymph node that we are seeing, this is a para-aortic lymph node. You will just see aorta coming into picture. Now this is the aorta coming into the picture. As I mentioned, the scope is positioned in the second part of the duodenum, the EUS scope. And then you can see a hypoechoic, round, 1 centimeter sized lymph node. This is something which is very typical of a malignant lymph node. We are puncturing with a 22 gauge FNA needle, and we take multiple passes. So this is to and fro movements that are being done. Around 10 to 14 to and fro movements are done. And we do this around 2 to 3 times to get tissue. So while we are doing EUS in this particular case, what we found in the mediastinum is, you can see this liver coming into picture, and this is the IVC which is going into the right atrium. This large heteroechoic structure that we are seeing as of now is the large lymph node. This is the mediastinal lymph node. This is the left atrium. This is the pulmonary artery. This is the subcarinal window in which we saw a large heteroechoic lymph node. We sampled this lymph node as well, again with a 22 gauge FNA needle, multiple passes. We made around 2 passes for this, and these are the to and fro movements that we are making as of now. This is, again, as I mentioned, 10 to 14 to and fro movements, 2 to 3 passes does the job. And what we got here was malignant cells. So this was convincing again of dissemination. So we did a study also. This was primarily a malignant mediastinal lymphadenopathy detected by EUS-guided FNA in patients with pancreaticobiliary cancer. So in pancreaticobiliary cancer, those lesions which are considered to be resectable on CT angiography, we did an EUS in these patients, and what we found, around 75 patients we had, that 7 of these patients had malignant mediastinal lymph node which were proved on FNAC. So this changes the management. Those patients who were considered to be operable now were deemed unresectable. So we have a malignant extrahepatic biliary obstruction caused unresectable periampullary cancer, as both retroperitoneal as well as mediastinal lymph nodes was positive. ERCP that we do for palliation of jaundice, that is to decrease the jaundice, was tried twice at 2 days interval. However, the cannulation failed, which does occur in 5 to 10% of the patients. So the options for failed cannulation that we have as of now, the standard approach is a percutaneous approach, and recently what we have is an endoscopic ultrasound guided approach. So EUS guided approach is primarily an alternative to percutaneous transhepatic biliary drainage in patients who ERCP has failed for some reason, and these reasons predominantly include inability to reach the papilla, which can be because of outlet obstruction or a post-surgical anatomy, or what we can have is a failed ductal cannulation, which can be because of inability to identify the papilla, large juxtapapillary diverticulum, tumor infiltration, or a high-grade ductal stricture. So the options that we have for EUS-guided biliary drainage are predominantly 2. One is a transluminal procedure, another is a transpapillary. So transpapillary means the wire is ultimately going out through the papilla, whether from above down or from below up. A transluminal procedure is again between the 2 lumens. So what we have is a choledochoduodenostomy, where we place a stent between the first portion of the duodenum and the extrahepatic bile duct, which is in very close proximity to the first part of the duodenum. The second procedure that we do is a hepaticogastrostomy. So hepaticogastrostomy, where we position a scope, EUS scope, just below the G junction, puncture through the stomach into the left hepatic duct, and then dilate the tract and finally deploy a stent. So this is hepaticogastrostomy. Or rendezvous procedure is predominantly where we puncture the left hepatic duct, pass the wire through the left hepatic duct, through the bile duct, which comes out through the papilla and then through the duodenum. Then we pass a normal scope, normal side wing scope, grab hold of this wire and do a normal ERCP. So this is what rendezvous procedure is. An antegrade stenting is where after the passage of wire through the left duct, through the common bile duct, through the papilla and the duodenum, over this we deploy a stent after dilating the tract. So this is what an antegrade procedure is. We'll be discussing about choledochoduodenostomy and hepaticogastrostomy. So as I mentioned, these are the important steps of a choledochoduodenostomy procedure. We do an initial puncture, tract dilatation, and place a stent. So this is how it is done on this video. You can see this is the bile duct. The scope is positioned in the first part of the duodenum. We punch with a 19 gauge FNA needle. So this is the 19 gauge FNA needle. Then we instill contrast to delineate the biliary system. Then pass a wire. This wire goes up to the level of hilum, and we want to be sure that has reached up to the hilum after delineation of the biliary tree. Then we dilate this tract with a 6 French cystotome. This is a cautery enhanced device. You can see the cystotome reaching up to the level of hilum. After the tract is dilated, what we do finally is place a stent. What we use is a 6 centimeters partially covered stent that it is uncovered on the ends, 0.5 centimeters. So the tip is reaching up to the level of hilum. You can see this last uncovered portion, and this is in the first part of the duodenum, and the bile will drain. So this is a typical biliary drainage that we achieve with EUS-guided choledochoduodenostomy. So this is the position of the stent after the procedure. This waste is at the site of the fistulous tract that we have created. So if we talk of this procedure, it has got a success rate to the tune of 94%. However, there are complications to the tune of around 20%, and the usual complication includes bile leak, bile peritonitis, perforation, bleeding, and pneumoperitoneum. So this is, again, we published our experience. This is one of the largest single center study using partially covered SEMS. 30 patients, 20 failed cannulation, and 10 we couldn't do because of duodenal stenosis. 6 centimeter partially covered stent that we used. Technical success was 93%, clinical success 100%, adverse event to the tune of around 10%, which was bile leak, hemophilia, and stent block. And these all complications could be managed conservatively. No mortality, 3-month dysfunction-free stent patency was 83%. So this is what we did in this particular case. However, the other option that we have is an EUS-guided hepaticogastrostomy. This is typically performed when you have a duct diameter of more than 5 millimeter, and the hepatic segment length, we need to have at least 1 to 3 centimeter to perform the procedure. So when we inject contrast, this ductal system is the B3 segment that we see, and this is the segment that is usually punctured for doing a EUS-guided hepaticogastrostomy. So this is one of our review where we have published how to identify the liver segments on EUS. So as you can see, the cranial segment is a segment 2, while the caudal is a segment 3. And as you rotate the scope, these will unite together. So this anatomy becomes very important to identify when we are doing an EUS-guided procedure, as we want to be sure that we are puncturing the B3 segment and not the B2 segment. So again, coming to the technique, we first position our scope just below the junction. This is a dilated bile duct, punch with a 19 gauge FNA needle, inject contrast, delineate the biliary system, and then pass a guide wire. This guide wire usually crosses the hilum, goes either in the bile duct or in the right ductal system. After we have passed the wire, we dilate this with a 6 French cystotome, and after dilatation of the tract, we place the stent. So here something very important is, since we are going through the stomach into the left hepatic duct, we want to be sure that this stent does not migrate. For this, we place around 4 centimeter segment of the stent in the stomach. So this is the stomach, this is the fistulous tract side, and this you are seeing a long segment of the stent in the stomach. And this again starts draining bile as soon as the procedure is complete. You can see again a waist here, which implies a site from where we have created the fistula. This is our EUS scope to do the procedure. Again, if we see the technical success, high 87%. Complication, again, high reported in the literature, this is 27%. There are certain limitations of hepaticogastrostomy. It's only feasible when the left intrahepatic system is dilated. If you have an ascites or coagulopathy, these are contraindications for the procedure. So coming back to our case, what we did in this particular case was EUS-guided choledochoduodenostomy, that is creating a fistula between the bile duct and the first portion of the duodenum. This was primarily for palliation of jaundice. Patient became afebrile and achieved complete biliary decompression. Bilirubin decreased to 10 gram per deciliter, TLC normalized, and ultrasound showed no intrahepatic biliary radical dilatation. So though we did an choledochoduodenostomy, what is traditionally done is a percutaneous transhepatic biliary drainage, and I'll come to the difference between these two. So how do these compare? So if we have at least, now we have many more studies. So these were the initial studies. two randomized control trials, one retrospective study. If you see the complication rate and the reintervention rate, both are high in patients who underwent a percutaneous transhepatic biliary drainage. Again, in this randomized study, the complication rate and reintervention was significantly high compared to EUS-guided choledochoduodenostomy. So in our unit, uniformly, wherever feasible, we are resorting to EUS-guided biliary drainage rather than a percutaneous transhepatic biliary drainage. This is again an important systematic review in a meta-analysis 2017, which shows the clinical success is almost the same. The difference, the technical success is the same. The clinical success was more in EUS-guided hepatogastroscopy. The adverse events were less in EUS-guided biliary drainage, and these complications predominantly included mild, moderate, and severe complications. In the severe complication, even death happened. Other were cholecystitis in the reintervention rate. The moderate complications included peritonitis, cholangitis, malposition, tube malposition, and the formation of a fistulous tract. So these were more common in patients who underwent a PTBD. So the conclusion of this meta-analysis was that EUS-guided biliary drainage may be preferred over percutaneous transhepatic biliary drainage if advanced endoscopic expertise and logistics are available. EUS-guided drainage is significantly better clinical success, lower rate of post-procedure adverse events, and fewer reinterventions. Technical success and length of hospital stay is same in both, and EUS-BD was considered to be more cost effective. BD stands for biliary drainage. So this is the algorithm that is followed once we see that papilla is accessible or not. If the papilla is accessible and there is a distal obstruction which is malignant, we do a choledochoduodenostomy. If distal obstruction which is benign, we do a rendezvous. If it's a proximal obstruction, benign disease, we do a rendezvous. Proximal obstruction, malignant disease, hepatogastroscopy is preferred. When we can't assess the papilla, which happens in outlet obstruction, we need to see whether it's a distal or a proximal obstruction. Distal malignant disease, we do a choledochoduodenostomy. Distal benign disease, we can resort to hepaticogastroscopy. Again, proximal obstruction, malignant disease, we do a hepaticogastroscopy. And for benign disease, hepaticogastroscopy if other advanced endoscopic procedures are not available. So what we have in this index case is still now a malignant extrahepatic biliary obstruction cause unresectable periampullary cancer, post EUS-guided choledochoduodenostomy for failed ERCP with biliary decompression. So after 3 days, patient developed fever with pain in the right hypochondrium and tenderness. TLC was high with predominantly polymorphs. GB was distended with thick contents with peripolycystic fluid, which was typical of empyema. So here, the diagnosis was gallbladder empyema. For this, the traditional option is a percutaneous tube cholecystostomy, and the newer option that we have and that we resorted to in this particular case was EUS-guided gallbladder drainage. So this is again a retrospective multicentric study comparing EUS-guided gallbladder drainage to percutaneous gallbladder drainage. And what was shown in this particular retrospective multicentric study was that EUS-guided gallbladder drainage seems to have shorter hospital stay, lower pain scores, fewer repeated intervention with a trend towards fewer adverse events. So this is what we did for our case. This is the scope is positioned in the antrum. You can see a distended gallbladder with thick contents here. So we used this particular stent, which is a fully covered metal stent, punctured with a 19-gauge FNA needle, dilated past a guide wire, dilated the tract with a 10 French cystotome. Here you can see the cautery going in, dilated this with a 10 French cystotome, and after dilatation, the last step is the placement of this biflanged stent. This is 14 millimeter in diameter, length is 2 to 3 centimeter. In this particular case, we used a 2 centimeter length stent, and we deployed a plastic stent across it just to ensure that this stent does not migrate. This is the pylorus, this is the stomach, and this is the puncture that we have done through which we have drained the gallbladder. So earlier also we have published this case. This was first report of an EUS-guided cholecystogastroscopy with the Nagi. This stent is known as Nagi covered metal stent for palliation of jaundice and extrahepatic biliary obstruction. So what happened in this particular case was we couldn't perform a choledochoduodenostomy, and this was the distended gallbladder. We used a different technique in this case that we published. After puncturing, we dilated with the balloon and then deployed the stent. So this is the stent that we used. So this procedure was not for empyema. This that we published, it was primarily for palliation of jaundice, in which we couldn't even do a choledochoduodenostomy. So coming back to the index case, after gallbladder drainage, fever and pain abdomen subsided, patient was discharged in a stable condition. So to summarize about EUS-guided biliary drainage, failed cannulation can occur in around 5 to 20% of ERCPs. Obviously, in expert center, this will be quite less. EUS-guided biliary drainage should be done by endoscopists skilled in both ERCP and EUS. EUS-guided choledochoduodenostomy is primarily for inoperable malignant lower end biliary obstruction. Hepaticogastrostomy is primarily for upper end biliary obstruction or patients with outlet obstruction. Choledochoduodenostomy or hepaticogastrostomy may be preferred before rendezvous or a PTBD, and it should be done in centers with surgical and radiological backup. A gallbladder drainage is an alternative to percutaneous tube cholecystostomy. So the patient came again 2 months after this with pain in the upper abdomen not relieved by NSAIDs and vomiting. So we did an ultrasound which showed there was no evidence of biliary obstruction. LFT was normal and endoscopy revealed presence of outlet obstruction. So what we planned in this particular case for pain relief was a celiac plexus neurolysis. Again, for this we have two options. One is a percutaneous, so traditionally that we do a CPN or a EUS-guided CPN. The other palliation that he merited was the palliation of outlet obstruction. Coming first to celiac plexus neurolysis. So celiac plexus neurolysis is a permanent ablation of the celiac plexus done either with phenol or alcohol, primarily for malignant disease. So you have to differentiate between a neurolysis and a block. So block is temporary inhibition of pain transmission done with steroids and long-acting local anesthetic agents. Primarily in chronic pancreatitis, it is done. So this should be done only if there is failure of opioids or there are intolerable side effects. So this is WHO step ladder pattern, which indicates that initially use NSAIDs. If the pain is moderate, you resort to mild opioids like codeine or tramadol. If it is severe, you resort to strong opioids, that is morphine or fentanyl. So this is what the WHO step ladder pattern is, which every one of us should remember. So EUS-guided CPN versus a percutaneous CPN. So what are the distinct advantages of EUS-guided CPN? One is ability to detect the ganglion. So on EUS, you can identify the ganglion not seen in this particular image, real-time visualization of the target area, reduced risk of neurogenic complications, avoidance of puncture of vessels as we are able to apply Doppler and see, and you target the needle precisely. With EUS, we have different approaches. This can either be a unilateral or a bilateral approach. So here you can see this is the esophagus, this is the stomach, this is our EUS scope, and from this just below the G junction you can see the takeoff of the celiac hair. So at the root of the celiac artery lies the ganglion. If you inject only on one side, this is known as unilateral approach. If you inject on both sides, this is known as bilateral approach. And on EUS, you can see this is celiac artery, this is the superior mesenteric artery. If you inject along the celiac and along the superior mesenteric artery, this is known as broad plexus neurolysis. So coming to the demonstration, the same, this is the aorta, this is the take of the celiac artery, this is the base I was talking of, this is the needle. You puncture just at the side of the base, and after you have punctured, you inject bupivacaine along with alcohol, and as you can see, 5 ml of bupivacaine and 20 ml of alcohol injected. You see clouding here, you can see nothing, and the whole procedure is completed just in 3 to 4 minutes, and you are done. So this is again our paper where we have used celiac plexus neurolysis for gallbladder cancer. Pain improved in around 60 to 70% of the patients, lowered daily analgesic dose for a period of around 8 weeks, and we did not have any complication. So this is EUS-Guided CPN pancreatic cancer systematic review and a meta-analysis. So here the only important thing in this slide is, with the different techniques that I have talked of, the response rate is approximately the same. And if we are doing a celiac plexus neurolysis, what we are talking of is a pain reduction to the tune of only around 2 to 3 months only. So again, this systematic review showed that there is no significant difference in response rate of 3 techniques. Serious complications were seen with the bilateral or with ganglion neurolysis, where we directly inject the ganglion. What we do in our center is a central approach, that is inject only on one side of the takeoff of the celiac. So EUS-Guided CPN is a useful adjunct to opioids for pain management. So there is a randomized controlled trial comparing CPN versus percutaneous CPN, EUS-Guided CPN versus percutaneous CPN. However, this study was done for patients with chronic pancreatitis. In our center, we rarely use CPN for chronic pancreatitis. This study showed that EUS-Guided CPN was superior to percutaneous CPN significantly. 70% pain reduction in EUS-Guided celiac plexus group and 30% in percutaneous celiac plexus group. So what was concluded here in the study, that EUS-Guided celiac plexus block appears to be better than percutaneous for controlling abdominal pain in patients with chronic pancreatitis. So to summarize about EUS-Guided CPN, it diminishes pain in 60% of the patients over 1 to 4 weeks. Modification of the technique, that is ganglia and broad plexus, are still being studied. There is no convincing advantage of one technique over another. We still need more randomized controlled trials to prove its efficacy over percutaneous technique. So the other problem is the palliation of gastric outlet obstruction. For outlet obstruction, traditionally what we use is an endoscopic duodenal stenting. Most of these patients are unfit for surgery. Otherwise, you have surgical gastrojejunostomy as an option. So recently, the addition is EUS-Guided Gastrojejunostomy. It's primarily an alternative to surgery in patients in whom outlet obstruction, in whom endoscopic stenting is not feasible because of some reason. So one is, why EUS-Guided GJ? When you already have an endoscopic duodenal stenting, you have the option of surgical GJ. The reasons are, one, it can be done in critically ill patients, short hospital stay, less painful, less invasive. It bypasses the tumor. We are not going through the tumor, and hence the chances of it getting blocked is quite less. Therefore, you have a prolonged stent patency. And now with advances in chemotherapy, the lifespan of the patient is increasing. Therefore, you need an option where the patency is more. There are certain problems which are associated with this. One is a special device that is required. Non-established, difficult endoscopic procedure cannot be done when there is a complete obstruction, that you are not able to pass even a wire through the duodenum, and possible serious adverse events. This again depends upon the expertise available. So before we resort to EUS-Guided Gastrojejunostomy, we should be doing a CT scan in all these patients, and this is primarily to look for diffuse involvement or involvement of the distal intestine. Otherwise, your GJ is not going to work. Determine the presence and the amount of ascites, because large ascites precludes an EUS-Guided gastroenterostomy, and there is a risk of leakage. So what we do in this particular case, GJ, is it can also be called gastroenterostomy, because the options that we have is communication anastomosis between the stomach and the duodenum, where it is known as gastroduodenostomy, or between the stomach and the jejunum, where it is known as gastrojejunostomy. So here the device, this is the device that we are using. Flares, these flanges are 28 millimeter. The diameter of this stent is 20 millimeter, and the length of the stent is only 1 centimeter. This is a cautery enhanced device, and this is the one which creates the fistulous tract. So for this, we have different technique. I'm not going into the details of all the technique. What we perform here is a assisted technique where first we pass a guide wire. Over this, we pass a nasojejunal tube, and I'll show you the video of what we do. So after placement of the tube, you can see this is the jejunum. Again, the scope is in the stomach. After distension with saline, this is how you see the distended jejunum. So this is distended. You can see the volvulus conventiis. You apply a color Doppler before you puncture with a cautery enhanced device which has got the stent loaded over it. You deploy the distal flange. So you can see the large distal flange that is deployed, and then finally you deploy the proximal flange in the stomach. So this is the proximal flange that is being deployed, and this is the capacious stomach that you are seeing. So in this fluid, what we do is we instill methylene blue. This is because once the stent is deployed, it will give you a blue colored fluid that tells you that you are in jejunum. So you can see the blue fluid coming out, and this indicates that we have positioned it right and not into the peritoneum. So after this deployment, you can choose to dilate this stent on the table itself, or even if you leave it, it opens on its own within a period of 24 to 48 hours. So as you can see, this is the balloon dilatation that we are doing. This was around second to third case that we had done. So we opened it up, and this was, we could see the tube, the nasojejunal tube that we have placed, and this is the small bowel that is being visualized. We did a barium to confirm that it's functioning, and then we did an upper GI. You can see the stent lying in the posterior wall of the stomach. You enter into this, and you can traverse whole of the small bowel easily with a scope. So you can enter into the small bowel easily. And this was done after 4 to 5 days. So post-procedure, the patient can be kept in the hospital for a period of around 3 days. You can give some antibiotics. Liquid diet is usually started after 1 to 2 days, and diet advanced as tolerated. And he can be discharged and allowed a normal diet, say after a period of around a week or so. So till date, we have done, still unpublished, we have done around 12 cases, predominantly malignant disease. And recently we did this for a patient in benign disease for group pancreatitis. And we have a high technical success, 90%, clinical success, 100%, and no complications in any of the patient till date. So this is a systematic review of meta-analysis of EUS-guided GJ done between 2016 to 2019. Again, high technical and clinical success, and the conclusion in the systematic review was it achieves a high clinical and technical success, relatively safe, might represents a non-inferior, minimally invasive alternative to surgery. So this is a study which compares EUS-guided gastrojejunostomy versus lab gastrojejunostomy, and what is shown in this multicentric study, again a retrospective one, that adverse events and the procedure cost was significantly more in patients who underwent a lab GJ. So this is a comparison between the three techniques: short time to oral feeding, short hospital stay in cases of EUS-guided gastroenterostomy, while if you see surgical GJ may be contraindicated in critically ill patients, and a high complication rate predominantly in the form of gastroparesis that you see post-procedure. So to summarize about EUS-guided GJ, it provides a more durable solution than antral stenting with shorter recovery time and less cost than surgical GJ. The patient must be chosen carefully, and favorable anatomy is required to achieve clinical success. However, still we need more studies, prospective and randomized controlled study. So coming back to our case, what we did was palliated biliary obstruction, palliated pain, and palliated outlet obstruction. So the last part of this talk is predominantly pseudoaneurysms that we see. So if we see the prevalence of pseudoaneurysm, it's 0.1 to 2%. Primarily, what we see in our department is a splenic artery pseudoaneurysm. The most common aneurysm that we see is a splenic artery pseudoaneurysm. And these aneurysms are usually asymptomatic, incidental findings, high risk of rupture to the tune of 20%, depends upon their diameter and location, depends upon the underlying disease like atherosclerosis or mycotic aneurysm, rate of growth, mortality if it ruptures may be very high to the tune of 25 to 100%. So splenic artery aneurysm, as you see on angiogram, prevalence is 0.8%. These are mostly saccular and situated in mid to distal splenic artery. Rate of rupture again in splenic artery aneurysm is around 3 to 20%. Treatment indications of a true aneurysm if the size is more than 2 centimeter, symptomatic patients. If the size is less than 2 centimeter in a pregnant female, you need to obliterate it. And patients who require liver transplant again need obliteration. All pseudoaneurysm should be treated irrespective of size or location. The reason is high risk of rupture and high risk of mortality after rupture. So the traditional treatment options that we have is endovascular approach and a surgery. Surgery again, good long-term data, however needs less intensive follow-up. There is a risk of mortality and there is a risk of complications. The endovascular therapy, which is considered to be the first-line approach, has got a high success rate to the tune of around 95%, avoids anesthesia, shorter hospital stay, lower morbidity and mortality. However, the problem here is we have retrospective cohorts, small numbers ranging from 4 to 113, variety of interventional techniques and a variable follow-up data. So why EUS guided therapy? It's again an evolving procedure, only a few published cases. It primarily involves targeting the aneurysm via a transgastric route and obliterating it by injecting thrombin, coil and glue. As I mentioned, why EUS guided? One, it avoids percutaneous puncture complications. It's a day care procedure done in conscious sedation, precise targeting of the aneurysm, precise injection, lesser expensive than radiological treatment. And this is the reason why we offered this in the first patient that we did in 2014 and can be repeated safely. So this is the technique that we do. You can see a large pseudoaneurysm. This is 5 centimeters splenic artery pseudoaneurysm. And you can see the blood flow. Once you apply Doppler, you will see that this is the neck of the aneurysm. This is the neck of the aneurysm and the blood flowing here. So what we do here is puncture with a 19 gauge FNA needle. We puncture with a 19 gauge FNA needle. And after puncture, what we do is deploy coils. So these are the coils which are thrombogenic and these are of variable size. The size depends upon the size of the aneurysm. What we deployed in this particular case was 2 centimeters diameter. The length is 14 centimeter long. And you can see after injection, the blood flow decreases. So this is the first coil that is going in. Then we place another coils as this is a large aneurysm. And after injecting coils, we inject glue. So normally we restrict to around 0.5 to 1 ml of glue. This is just to avoid the distant migration of the glue. And you can see Doppler has been applied and there is no flow in this aneurysm. So as you can see on CT scan, this is before and this is after. This is totally thrombosed. This becomes totally solid when you see it on endoscopic ultrasound. So this is the first case that we published. This was using thrombin alone. And after injecting thrombin, there was no blood flow in the aneurysm. So complete obliteration could be achieved. This is another report. This is the first report again of the literature that we published. This was using EUS guided coil and glue. This was large aneurysm in the setting of a chronic pancreatitis. And what we did here after injecting, you can see complete obliteration of the aneurysm is achieved. So this is again the first largest case series that we published of the literature. This is 6 case series. After these, we have done around 5 more cases. High technical success, high clinical success to the tune of 100% without any complications. So this is a treatment algorithm that I have taken from a radiology book. So as you can see here, what is suggested in the radiology literature that if you have a vascular excess, you do an endovascular procedure. If you can do an endovascular procedure, you go ahead with that. And the technique will depend upon the size of the neck of the aneurysm. You have different techniques. That is a coil sandwich approach, stent graft, stent assisted coiling. If you don't have an endovascular excess, then they suggest using an EUS guided approach. This is direct thrombin, glue, or coils, or you can do an ultrasound guided approach. However, what we strongly feel is that EUS can come up here as an initial approach even before we resort to an endovascular route. So to summarize, EUS for pseudoaneurysm, EUS guided coil and glue injection for splenic artery aneurysm is feasible with high technical and clinical success, no significant adverse events, and can be repeated safely if required. So to summarize, EUS guided fine needle aspiration is a minimally invasive, safe, high sensitivity and specificity. EUS guided choledochoduodenostomy and hepatogastroscopy may be preferred before a rendezvous or a percutaneous transhepatic biliary drainage. EUS guided choledochoduodenostomy for inoperable malignant lower end biliary obstruction. EUS guided hepatogastroscopy for upper end biliary obstruction and gastric outlet obstruction. EUS guided gallbladder drainage is an alternative to percutaneous tube cholecystostomy. EUS guided CPN provides a short-term pain relief, however, may be preferred over a percutaneous approach. EUS guided GJ is more durable than antral stenting with a shorter recovery time and less cost than surgical GJ. EUS guided coil and glue for splenic artery aneurysm is feasible, safe, with high technical and clinical success rate. Thank you.